Thank you very much indeed. Would you like to just say who you are?
I'm Dr. Jim Morrow. I'm a neurologist, or I was a neurologist, based at the Royal Victoria Hospital. I retired a few years ago because of illness, unfortunately. I'm really here because I set up the founder and the principal investigator of the UK Epilepsy and Pregnancy Register.
Right, thank you very much. Could you then describe for us what you consider to be the strengths of the registry, the UK Epilepsy and Pregnancy Register? And perhaps you could tell us if you think it could be improved, how it could be improved.
The first thing to say about the Pregnancy Register is it's a research project. It is not affiliated to any professional, academic or other bodies. It is simply a research project. The strength of the project is, and why I set it up, was not because of Valproate. The reason I set the UK Pregnancy Register up was because at the time, around the mid-90s, a number of new anti-epileptic drugs were coming on stream. And these drugs basically were tested on rats. And I thought, I'm not sure about that. Let's look and see if we can do better than that. And current monitoring systems really don't pick up pregnancy problems. They pick up acute adverse effects. So at the time, carbamazepine and Valproate were the two main drugs that were being used. So they really are comparators or controls, not, as I say, because we were worried about Valproate. With the retrospectoscope, yes, you can go back, oh look, that drug's been showing problems since the 1970s when it was first licensed. But actually, yes it was, but these were anecdotal, very small studies. And often journals that neurologists wouldn't particularly read, genetic journals or neonatal journals. So carbamazepine, Valproate, and a group of women who had epilepsy but were on no drug. Now, they're a bit of a funny group because if you're not on a drug, you probably don't have epilepsy anymore. But those three were our controls or comparators, and we set up really to look at the new drugs. Now, the only way you can really assess traginicity is to have many hundreds, preferably thousands, of subjects. Because of the background risk, you basically need about 300 subjects in each group to gain statistical significance. So we thought about how to do this. Basically, it was very simple. And I think registries have shown this. What we did was we asked, first of all, GPs, neurologists, etc., to let us know about a woman if she was taking any kind of anti-epileptic drug in the early stages of pregnancy. We would then contact the woman and get their written consent to follow up the pregnancy. And the basic thing was to follow the pregnancy up 3 months after the baby was born. Now, this was primarily then to look for structural abnormalities. And we thought, if you've got a structural abnormality, you probably still know about it after 3 months. And we go to the GP to get that information because he's the centre of all knowledge. But we have then the permission to contact other doctors that were involved in their care. So the strength of the registry is it was very well supported. And in fact, our main supporters at the moment are the women themselves. We get the vast majority of our referrals from the women because they're interested, not just because of their pregnancy, but because of other people's pregnancies. And we recruit them through our website and through our free phone. The registry has some 13,000 registrants, so it's really quite powerful. There was a lot of antipathy about it to start with, from neurologists, etc., who really didn't think it would work, and B, were worried that we'd show something that would get them sued. Maybe that's true. But basically, as I said, we set up to try and get as many thousands of hundreds of patients on each drug as possible. And as I say, we kind of achieved that. We needed 300 patients on each drug to show statistical significance. And we have that for most of the drugs that are around now. So the strength is the numbers, and the strength is that it's got a pretty hard endpoint vis-a-vis structural abnormalities. Now, as time went on, we realised the structural abnormalities weren't the end of the story. And we teamed up with the University of Liverpool, Professor Gus Baker and Rebecca Bromley, who you may have spoken to already, to do the longer term follow-ups on these. There is a weakness in that group because they tend to follow up small numbers of patients. And to my mind, we really again need large numbers to be sure of the actual incidence of neurodevelopmental delay, because that's the thing that's driving a lot of this at the moment, because figures of 30 to 40% of patients being affected is really quite worrying. The structural abnormalities come out about 10%, but again, some of these are minor, some can be corrected. And then we look in retrospect, how did we miss this? Well, if you're a neurologist, you might see one woman who's pregnant on a drug every year or so, and if somebody has spina bifida, that happens. So it wasn't picked up. It was not like thalidomide, where the abnormalities were really unusual and became obvious very early on. This has been going on for 40, 50 years with valproate. And it's only really been picked up since the registries were founded. We were the first national registry. The Europeans came along, and then the North Americans and the Australians. And the good thing is, we're all very powerful. We've got thousands of pregnancies, and we all tend to agree on the outcomes.
Right. Well, thank you very much indeed. I think it's very interesting what the history is, really, that you were really doing a research project.
Yes.
And it's now become the first national registry, you said, in the UK. But thinking about the parameters of it,
Yes.
do you think that it could be improved? Because one of the things that you've told us is about the 3 months after
Yes,
the baby
yes.
is born, and clearly some of,
Yes.
especially perhaps neurologically,
Yes.
there are other issues that come. So would you think of changing the registry and perhaps making it more comprehensive?
Yes.
Because as I understand it, it's voluntary.
It's totally voluntary. It is a research project. At its peak, we were recruiting about, we reckon, 30% of all the pregnancies in epilepsy in the UK, which is not bad for a voluntary research project. The numbers have tailed off because doctors now think they know it all, and they don't. There are other drugs that are coming along that we have concerns about. The obvious thing is that the yellow card system and other monitoring factors don't work. Registries are very, very simple. I mean, we've got one nurse part-time who essentially runs this. So, I mean, it really needs to be taken over, I think, by an administrative body who will ask not just about anti-epileptic drugs, there are antidepressants, other drugs that there are suspicions about, are these drugs safe? And doing it all the way with a 3-month outcome, it's a solid, secure outcome. And the structural analyses tend to indicate whether a drug is triogenic or not. And if it is, then you can look further on. The other studies are very important, the neurodevelopmental ones. And I think that would be something that needs to be extended with the registry. Vis-a-vis, we've got some 1,500 valproate outcomes. These kids should be assessed later on. Many of them are at school now, some further on, because it's been going since 1995. And it wouldn't be rocket science to try and get hold of some of the school assessments and tie it up with the drugs that people were taking. Rather than do full neuropsychological assessments, which are, very intense and require, to do 1,500, I don't know how long that would take. But I think extending it, making it more compulsory, extending it to other drugs in pregnancy, and looking at longer term outcomes, I think would be important.
One of the things that we've been considering and thinking about is the difference between a database
Yes.
and a registry.
Right.
And one of the reasons on the database is that it is, well, actually I'm going to ask the expert on
Okay.
this because he has set one up. So,
Okay.
Cyril, would you like to, rather than I read out the definitions.
When were you setting up this? How long ago? It's about
1985 I started, yeah.
Yeah, well, but in the 1970s, I was involved in setting one up for children
Yes.
with end-stage renal failure, which is nowhere near as large as yours. So, but it was across Europe, and of course it was entirely voluntary. But
Yes.
basically, every unit registered the name of the patient. We asked the patient, he said fine, and it was comprehensive. The world has changed hugely since then, and you just said it's got to be compulsory. You just used the word. And the trouble is, under GDPR, you can't do that.
No.
So leaving to one side whether it should or it shouldn't, what is necessary is to try and make them as comprehensive as you possibly can. For research purposes, you're absolutely spot on. But for once you go beyond that into long-term surveillance, then you do need it to be as comprehensive as it can be. And you need personally identifiable information, not anonymized information.
Yes.
At that point, you do run against, and rightly so, the common law duty of confidentiality and now the general data legislation.
Yes.
So what we've been wrestling with this, and we're still working our way through it, is we are testing whether under GDPR, and there are 5 ways you can introduce this under GDPR, and one is a legitimate interest which can be mandated by a competent authority, which might be the Secretary of State. And that means you can create a database. And that means that you register every event for an operation the surgeon will register, and we've discussed that at the present Royal College of Surgeons in public. For medicines, there are other ways of doing it through the prescribing system. That would be on the database, but it would not be a register. To create the register, you can use the database, but you've got to get permission from the patient for their name to go on the database. But once you've got that, then you can find out who the patients are by linking to the database. So we've been distinguishing between a database and a registry. And so your patients are patient identifiable because you've got permission.
Have to be,
They have to be. So this would be a way of striving, A, to make it more comprehensive, and B, to be able to keep it going beyond 3 months so you get long-term outcomes. So with that tortuous explanation, how do you react?
There's one slight difficulty. You've no idea how many women change their names. The child moves around.
I'm going to interrupt you. It's called the NHS number.
Right. Right. Okay. So that's a traceable. I mean, these things are beyond me, basically. You know, as I say, this was set up to be a very simple project, and the patients are identifiable, and we give their written informed consent, and we put it all into a database.
Baroness Cumberledge and I were involved ages ago in the introduction of the NHS number, and that was the purpose of it.
We haven't got that. That's not on our form, you see. So that is a very good idea, actually. If we had that, because it is sometimes very difficult to trace these kids as far as time goes on.
So how many? Because I mean, you do 3-month follow-up.
Yes.
What's your sort of loss rate of being able to find?
It's not that high. It's about 10% perhaps. We've got pretty good at trying to track people down.
You'll find.
But as I say, it really runs with a shoestring. I mean, it's really one part-time nurse that really runs the whole thing, with us harping on about it and presenting it to anybody that will listen, basically, to professional bodies, academic bodies, etc., etc.
Can I ask you how your register is funded?
Right. We had huge difficulty getting it funded at the outset. Professional bodies, academic bodies, grant providers were not interested in this. So we reluctantly went to the pharmaceutical companies. I was very reluctant to get money from one pharmaceutical company. They were very interested in this because they thought they would see it drug. I was not going to accept money from them unless I could get equal amounts from essentially all the drug companies. So at least it was fair. And we got about £5,000 from each of the drug companies.
Right. So do you have some sort of governance arrangements to ensure that people respect your integrity?
I think people do respect our integrity, but I'm not sure we have things laid down as to why. I think people just know that we're a group. It's monitored by a group, a multidisciplinary group who meet every 6 months. They're all from around the UK, with obstetrician, GP, other neurologists, genetics, and so on that, who oversee it. So, I mean, we're all professional people, and hopefully people will understand that we have no interest beyond actually trying to prove whether the drug is safe or not.
So the university doesn't insist on that?
No.
No.
Well, I mean, we've got ethical approval to do this, and that was a nightmare at the outset as well, because at that time you had to get ethical approval from every single university in the area that we were recruiting patients from. Happily now there's multi-centre ethical approval, so we have that obviously.
What about clinicians themselves, neurologists,
Yes.
GPs and so on? How willing have they proved over the years to...
As I said, there's initial antipathy to it, but once we started to present results and say, look, here we are, and this is what we're doing, and actually, you know what, doctors trying to stand out a wee bit here. We need to know this, and they really have bitten into it. I mean, I don't think you'll come across a neurologist or GP who doesn't respect what we do and is anti it now. They actually think this is a very useful tool. So, you know, we've never had any problems with them.
Why did they hostile to begin with?
I think they thought that if we showed something, they might get sued. I mean, facetious, Pepe, you know. But I think to a degree that's come true. I mean, are quite vocal about this, and a lot of their thing is getting, you know, holding people to blame for this. And I think, and I don't want to get involved with that. That's not what I'm doing. I'm trying to improve things.
Can I ask you about the feedback arrangements of information
Yes.
between what you find in the registry and the industry? So
Yes.
was there any buy-in? What did they think they were buying into?
Who?
The industry, pharmaceutical companies.
The new drugs, they were buying into it because people had a reluctance to prescribe them to young because they weren't sure. And happily we were proving most of them to be safe. Now there is one that's coming out with a tragic profile very similar to valproate. And the MHRA are not listening to us because we're flagging this up. I flagged this up to them, and they said, we're going to do what we are. Valproate's our subject. It's a drug called topiramate.
Sorry.
Topiramate. Topiramate. Yeah. Now this is very bad because topiramate is an anti-epileptic drug. We have about 150 outcomes on it. So, but it does seem to have a tragic profile, at least as bad as valproate. We've just got funding to do the follow-up studies, developmental studies. Neurologists, however, happily don't use topiramate too often in epilepsy because it causes a lot of psychological effects, and we've been saying about it. So numbers of use in epilepsy are quite low. That's why we've only got 150 outcomes so far. Where topiramate is being used, though, is in migraine. It is by far and away the best migraine prophylactic agent. Vis-a-vis, if you're getting more than 2 migraines a month, you take this drug on a regular basis for 3 to 6 months. Who gets migraine? Young people, young women. You take away their headaches, they can get pregnant in this drug. And it's worse, this drug interacts with a pill and makes the pill less effective.
Is this off-label prescribing, or is it?
No, it's licensed.
And are you, sorry, how aware did you say prescribers are of this?
Neurologists are aware to a degree because we've been presenting it to them. I've talked to the MRHA when I was there for the Pregnancy Prevention Bureau about this, and they said, look, we're not interested in topiramate. We are where we are, valproate's what we're going to try and prevent. And I said, well, I said to them, you'll be back here in 5-10 years' time talking about this other drug.
Do you have any data on the overall prescribing volume of this drug?
I'm sure somebody could get that, but I'm a jobbing neurologist.
Can I just ask a question about
Yes,
that?
can I just follow up this, though, just one thing. So, have there been clinical trials on this drug?
The only clinical trials are at the outset, where you do randomized controlled trials, but what you're interested there is the efficacy of the drug. And you're interested in side effects, but you've got to bear in mind, randomized controlled trials consist of 20, 30, 40 patients.
Yeah.
And they're not allowed to get pregnant. They've got a sign of things saying they mustn't get pregnant during this trial. So this is only after a drug gets licensed do you run into these pregnancy issues. And at the moment, the monitoring systems won't pick that up.
Are there any warnings on the packets?
Well, there are on some of them now. I should have looked at the packets before I came, but the BMF would tell you whether they're
I've got the BNF over
Yes.
and it does have increased risk of major congenital malformations following exposure during the first trimester.
in time to pyramid.
Yes.
Yeah, well, that comes from us. They've got that, but
But how strong that warning is to patients is
Yes. Well, we can't be too strong because we've only got about 150 outcomes, and as I said at the outset, we need 300 to be statistically significant.
And that presumably is sort of major physical malformations.
Yes.
There's limited data on them.
We've got Rebecca, Bombay has just secured, I believe, some funding to do the neurodevelopmental studies following this.
But at the moment, you haven't been able to prove this, but you are strongly.
Yeah. I mean, I think it is statistically significant because it's a 10% rate, same as valproate.
I guess have other registries and other countries found the same?
Yes.
And there's a consistency?
Yes, but I think the numbers are always quite small because the drug hasn't been around that long yet. And it's not now widely prescribed for epilepsy because people are aware of this and they also don't like it because of these side effects.
But as you say, it is widely prescribed to people who are in the childbearing age.
For migraine usually. It's a great drug for migraines.
But presumably it's very effective in terms of controlling epilepsy.
The worry here is that valproate has been around for 50 years. It has side effects. It causes weight gain, it causes hair loss, it causes thrombocytopenia, drop in your platelets, bleeding problems. And the teratogenicity now is pretty well known. But we still use it. Why do we still use it? Because it's a very effective drug. And the problem is it's very effective for what are called idiopathic epilepsies. Epilepsies where there's no discernible cause. And this is young people usually. And it is by far and away the most effective drug for many of them. And for some of them, it's the only effective drug. So that's why it continues to be prescribed. We'll never get rid of it unless we get another effective drug. The second most effective drug for these type of epilepsies is topiramate. So we could be driving people to use topiramate more often. We'll be back.
Have you seen any evidence in terms of changing prescribing practice?
Yes, valproate prescription has gone right down.
And has topiramate sort of kicked that up?
It's hard to tell because we've got so few on it, and we don't register migraines. Yeah, and I think if we did that, you would see a rise. Yeah, this is speculation. I don't like to do that. But
would it be sensible, given there seems to be an overlap between the sort of products used to treat epilepsy and migraine, the register covered?
Yes. But I think it should be for all drugs that are going to be used over periods of time when women can get pregnant. I mean, antidepressants, there's always been a bit of suspicion about them, but nobody really knows. So I mean, it's not really rocket science. And as I say, we do it with one part-time nurse. I'm sure the regulatory bodies could do something similar.
Does your register link to any other databases?
No, not really.
So it doesn't link automatically to the yellow card system?
No. Maybe it should.
Yes.
And I think that's what I'm saying. The yellow card could include effects in pregnancy, but you have to do it slightly differently than how the yellow card system works, where a doctor just fills it in because somebody's got an acute side effect. And when somebody comes along with a child who's got educational difficulties 6 years down the line, you don't necessarily relate to what the woman took during pregnancy.
Yeah, I understand.
Just on your point about the MHRA and their reaction when you told them about the pyramid.
Yes.
Does that mean, as far as you're concerned, they're not the MHRA collectively, not just the...
Well, it was just a meeting about the pregnancy.
Yeah, sure, that's why and
I have concerns about it to start with, okay? But when I said that you're doing valproate, but are you thinking about other drugs? No, we're doing this because this is where we are. And I went, well, hold on, I don't know that's the only thing.
So we don't know to what extent there are yellow card reports relating to pyramid.
I suspect there's very few, if any, regarding the pregnancy outcomes.
Yeah.
There will be quite a few about psychological effects that can cause psychosis and things. So we don't like it particularly. But in migraine, you're using it for a short period. You see that it's so good that you still use it.
But in the context of pregnancy, given that what your early data is suggesting is that it has similar risks to valproate.
Yes.
Are you surprised that the MHRA said they don't want to look at it?
I was taken aback. I mean, Valprio's been around for 50 years, and we've been presenting this since, with pretty strong data since the early 2000s. We're in 2019, I mean, why are we discussing this? This should have been flagged up a long, long time ago.
Why do you think it hasn't?
Well, one of the problems is because Valprio is such an effective drug. And it's, although, I mean, I would say, I'm speculating a little bit, but prescriptions for Valprio to young women, to my mind, has dropped. Because neurologists who generally prescribe the drug, paediatricians as well, and other people, paediatricians aren't quite as aware, but certainly neurologists are very, very aware of this problem now, and will be reluctant to prescribe it, except to certain epilepsies like juvenile myoclonic epilepsy, where it is basically the only drug that will work.
Are you picking up in your register the impact of switching from one drug regime to another during pregnancy? Does that, are you getting information?
Yeah, we've got limited information that we haven't specifically looked at it. It's kind of tricky switching. I mean, for structural abnormalities, there's no point in switching because that's a first trimester problem. And you can't switch. It's bringing down one drug and bringing up another drug. And it'll probably take you about 3 months. However, the neurodevelopmental stuff is probably not just the first trimester, it's all the way through. So there's an argument there to switch the drugs. The trouble is, of course, when you're switching for a period of time, maybe up to 3 months, somebody's on 2 drugs. And polytherapy carries more risk than monotherapy. So you're between the devil and deep blue sea.
In terms of the drop-off in Valprio prescribing, can you tie that to the introduction of the toolkit or the pregnancy prevention program in terms of timelines?
The pregnancy prevention program has not been around for very long.
No.
What was the other one, sorry?
The toolkit that was introduced in 2014.
I think it's been falling before that. I mean, we've been jumping up and down about this since the very early 2000s. And I think neurologists have bitten into that.
Right.
I mean, you can probably get the data, I can't. I'm saying that there'd be a drop-off because of our registrations really falling for Valprio. And as I say, we think that we reflect prescription levels, but it's not all of them, it's at a percentage of those prescriptions.
Yeah.
Right. So.
In terms of your registry, obviously it's been running since the mid-80s.
Yes,
So
mid-90s.
Mid-90s, sorry. Do you have the capacity to look at, say, transgenerational follow-up at all?
How do you mean by that?
In terms of the children who were exposed in
Yes.
utero are now adults?
Yes.
Their children?
No. But you're right. I mean, ours is a very, very simple project. We made it as simple as possible. We just took data at the time, and all that was the patient's name, the GP's name, and the drugs that they were taking. And then 3 months afterwards, we contact the GP and find out if there's been a problem. Now we have that data, it's not anonymised, so we have the patient's name and we have the GP's name, so we can, and that's how we did the neurodevelopment stuff. That's very interesting. That data's all there, and these kids now, 1995, are, you know.
It seems to me you're demonstrating to us a fundamental truth, and that is if you're going to do an experiment, you have to design it properly and carry it through. What you can't then do is take the information and just automatically apply it to another issue and hope that it will give you valid information.
Yes. The good thing though, when we set it up, when we got the informed consent, we got the consent for long-term follow-up. There was no time limit. So we can do what you said.
Can go
but you know, I mean, I'm a jobbing neurologist, I'm retired now. There's a team, we've got jobs, and we've got one part-time nurse.
Yes.
So you guys maybe go to...
So, you were starting again, and you had plenipotentiary powers.
Yes.
What would you say we should do in our country to set up a better system?
I mean, I think it would be useful to set up, through the CSM, Leaf City Medicines or whatever, registry type systems to look at drugs taken by young women when they're pregnant, and ask for follow-up through their GP. And you will pick up pretty quickly, because as I say, you need about 300 patients to show a doubling of effect, whether there is a major trigenic effect with regard to structural malformations. And if there is, structural malformations are a good indicator that there may be other issues further down the line, and then that drug could be followed up. There's another thing you could do. If a woman has a child on valproate with a problem, you can bet your bottom dollar if she has another child, that child will also have a problem. Whereas if they have a normal child, they will probably have another normal child. So you have to ask yourself, why are 10 to 20% of children affected and the other 80% aren't? So to me, it's not just valproate. There's something in the gene that is making that child susceptible. And if there are studies done to try and identify that, then you could target the women that are going to have a problem and make sure they don't get valproate, but the rest can. Because we haven't at the moment got an alternative.
May not be in the child's gene, it could be in the mother's.
Yes. Could be all the fathers.
Because we do know that picking a drug which is also occasionally used in migraine, clopidogrel, that some people activate it faster and some others don't. And that could apply, I guess. Yeah.
But genetics has moved on so much, you can do whole gene analysis and stuff. My bet would be it's in the child's gene, because the child's susceptible. That's what do I know about genetics?
Any questions?
Just one actually, because of course you did say that you were looking at the new generations of drugs that came up in the 1990s, so that would have been the sort of Keppra generation?
Yes, it was lamotrigine and gabapentin first of all, and then it was levetiracetam, Keppra and topiramate. So they've come, yes, but it's still there to look at other drugs.
But those are not causing you concern?
No.
And have not?
And we've got good, lamotrigine is now, like thousands of patients on lamotrigine, we're pretty secure in it.
And likewise with Keppra?
Yes.
That was the one we thought that people were being diverted.
Yes, they are. Yeah, but it's not as effective against certain types of idiopathic epilepsies that epilepsy is used for, and that's a big problem we face. We'll not get rid of it, even with the pregnancy prevention program.
And is that structural abnormalities, or have those progressed onto neurodevelopmental studies as well?
We haven't really got the neurodevelopmental studies on those drugs, but as I say, we're interested in topiramate, and Rebecca's got funding to do the topiramate follows up. But I say you could do it differently and probably cheaper if you got the kids' school records with what you suggested there.
You really have struck a chord here, because, and I don't mind this being videoed, because I and others have been trying for years to get the schools to register the NHS number for children with chronic illnesses, particularly epilepsy, asthma and diabetes, so that we can do just that. And so I'm very grateful to you for giving me that opinion in public. Thank you.
I mean, we in Northern still have 11 plus. Wouldn't that be great if you could get the kids 11 plus results and tie it up with whether they do that? See, the trouble I have with the neurodevelopmental studies is that they're very small studies. They're only 20 or 30 patients, and they're often by the same authors, and they're often recycling the patients, and there are some selective bias in those studies. So, and they quote these big numbers, and that's driving all of this, and I just worry how strong that evidence really is. And the way to do it, as I say, is to do longer term follow-up on bigger numbers. But that's open for debate, and how you do it, I leave that to you guys.
Dr. Morrow, I'm sorry, I'm afraid I've got to bring this to a close, because we've got another group coming in a minute, and there may be other questions that perhaps we could put to you in writing or whatever. And same for you, if there are things that you think we've missed out and you'd like us to know, please let us know. But I do congratulate you. I think it's terrific what you've been doing, and certainly with so many barriers in the way in terms of funding and other things, but it really has been a step forward. So thank you very much indeed.